So I'm really excited. For those of you who don't know, I'm Dr. Eric. I'm the founder and be presenting on how to recover naturally from hip pain without medications, drugs, and surgery without downtime. This is the first time we're offering this, so I'm really excited about that. And the format of this presentation is pretty straightforward for those of you that haven't been to one of these before. I'm going to introduce myself and some people on the team because I think it's important for you to know why we're here, who we are, and what we do. I want to hear from you, what brought you to the presentation. I'm going to present some information about hip anatomy and things that can go wrong with the hip. I'm going to talk about some recent research and what people are getting with clinical results of people with hip pain. We're going to have a demonstration, if you will, or what's called a 5-minute miracle. That is an opportunity for you to see what a hip assessment and examination looks like. And then I'll let you know what best steps are for those of you that want to pursue a solution to your problem. Fair enough?
Mm-hmm.
Outstanding. Let's get rolling. So, okay, thank you kindly. So at Physical Achievement Center, we help people achieve greater mobility and strength for their active life without medications, drugs, and surgeries, even when nothing else has worked. We are starting our 7th year, and this has been the mission from the inception. I have over 30 years of clinical experience. Nearly all of those were in Oshkosh in a wide variety of settings. I had the privilege of training as a fellow in the American Academy of Orthopedic Manual Physical Therapy, which doesn't mean a whole lot to individuals in the room perhaps, but I had a chance to look at clinical research and clinical applications for helping with individuals with pain relief from head to toe. Based on that, I realized that we can offer more to the individuals in the community for their muscle, bone, and joint problems. Dr. Rebecca is a clinician here, has got over 10 years of clinical experience. She's specially trained in applied functional science, helped a number of folks in the community, as you can imagine, and she's a certified dry needling practitioner. Dr. Jessica, she's specially trained in spinal and upper lower body mobilization and manipulation, certified vestibular therapist, specializing in dizziness and balance. She's in a fellowship program right now, and she's certified in dry needling. She's probably one of the top 5 trained clinicians in dry needling in the state right now with the extensive background that she's had. Gina is a physical therapist assistant who's specially trained in pain relief and sports recovery massage. She's a certified spine specialist, certified lower body specialist, and she is exceptional, and she's been here for several years. Courtney is a physical therapist assistant who has extensive experience in home health. She's specially trained in pain relief and sports recovery massage, certified spine specialist, certified upper and lower body specialist. Robin Barber is a clinician who's got over 25 years of experience in the hospitals with CT and tomography. She's specially trained in neuropathy, and she's our wellness lead. Laurie Shades is a clinician who's got over 30 years of experience as an occupational therapist. She's specially trained in lymphedema, and she's the first clinician that I brought on board here. She's a fierce patient advocate. And then in the room here is Bren. Bren helps at the front desk and helps create a great team experience as well. So the bottom line of why, this is the first time I've seen this picture, this is great. This we need to update that though, because there's no team members, but we help people make better healthcare decisions is what we're after, right? Anybody heard the term evidence-based practice? The term anybody's heard? Yeah. So evidence-based practice basically means that we want to use a combination with the patient at the center. So patient preference is the center. So if we think of 3 circles, another circle would be practitioner experience. Another circle would be, what does the research say? So when those 3 things combine, when you have something that's in line with what the patient would like, something that's in line with what the practitioner is good at, and something that is in line with what the research says works, and all those meet, what are the chances of good outcome, do you think? Pretty high, right? The challenge is if you don't know all your options, can you make a really good decision? You can't. that was a frustration that led me to start the practice to begin with. First and foremost, we want to educate people on their options. Obviously, we'd like to invite people into our world to help them with their condition, but it's important that we help identify that there's more options than there's going to be for what individuals are currently experiencing with their problem, and that's why we exist. We want to bias towards natural healing without medications, drugs, and surgery. And we certainly don't want to do this, and you can finish the sentence for me. Okay, once you finish the sentence, what do you expect? Help me finish the sentence. Have you ever heard this? What do you expect at your age? Has anybody ever heard that? Another practitioner? Yeah. We pay people a lot of money to say silly things like that. We can do better. So, okay, we'll talk about mistakes that hip pain sufferers make. Do nothing. And I don't know if that applies to the people in this room because you're coming forward and get some education, so that's great. The longer you have a problem, it doesn't help the healing time, right? It can take a little bit longer to recover. So there's really no advantage to waiting, if you will, if you know there's a suitable solution for you. Another mistake individuals can make with hip pain is try to mask it with over-the-counter pain medications, lotions, potions, prescriptive medications, including non-steroidal anti-inflammatories, and particularly muscle relaxants and opioids. What are the side effects of over-the-counter or prescription non-steroidal anti-inflammatories, anyone? Ibuprofen, stomach issues, right? Kidney damage, liver damage. It can actually increase the risk of cardiovascular events. So it's significant. So to rely on those for a long period of time carries their own risk, even though they can oftentimes mask the symptoms. Ignore comprehensive treatment. We'll talk about what comprehensive treatment looks like. And think about a single solution to your hip problem. Thinking that surgery or injections alone could manage it. And we think there's better options. So we don't want to avoid missing out on our favorite activities. Many of you mentioned wanting to remain active, sleeping through the night, being able to walk, being able to participate in those gym-based activities with your friends, and keeping up with your friends and family. So I'm going to provide a little bit overview of anatomy, if you will, of the hip joint area. And so this is me sitting here, if you will, a model of this. And I'm going to show you a couple things in particular. So you have 24 vertebrae from the head to the bottom of the sacrum, and then you have your pelvis that wraps around. Your hip joint is comprised primarily of your side of the pelvic bone and your upper leg bone. So as you're sitting where your pant crease is, right in the center here, between your groin and the side of your hip, is actually your hip joint. When you lie on your side and you feel that bony bump on the side, that's not your hip. That's just a bony bump on the side of your hip, known as your greater trochanter. So every hip joint, each hip joint is fairly close to the lower back, right? I mean, it's not that far from the lower back. So you'll find there's lots of relationships of the lower back to the hip and the hip to the lower back. In fact, there's an actual condition that's called the hip low back conundrum. And I always say if you've got a hip specialist and a spine specialist together and you loosen them up a little bit with a couple of drinks and you ask them, can you know for certain if someone presents with pain somewhere in the front of the hip, side of the hip, or even the lower back? Is it a back problem or is it a hip problem? If you had a couple drinks in them and they were honest, they'd probably say, not always, right? Because they influence each other. We're going to talk about that. Hip joints should be capable of a lot of movement. When we sit, our hips should get easily to not only just 90 degrees or a right angle. You can imagine someone sitting like this, facing that way. They should also be able to flex up a bit more than that. Also, hips should have a lot of in and out motion. That's represented by kind of a hacky sack movement, if you will. So we'll talk a little bit about that. Bones come together and have cartilage over it, as we alluded to, and then you have strong cartilage, if you will, and strong hip joint capsule. We'll talk a little bit about that in the slide presentation as well. So it's a basic orientation. Again, from the back view, the hip joint here is fairly close proximity to the lower back. Individuals with hip problems can experience and feel pain in the front of the hip, side of the hip, back of the hip, maybe even down the leg. We've had individuals who present to us with knee pain, even lower leg pain that have hip problems as a source. We have individuals with lower back pain who actually have a hip problem as their primary cause, right? So we're going to talk a little bit about that. So the first area of concern is a condition called osteoarthritis. It's the most commonly diagnosed condition in individuals who are in the age group of folks that are here. It's referred to as a degeneration or a change in the joint tissue and the underlying bone, if you will. There'll also be a change in the flexibility of that hip joint. So on x-ray, this is a nice smooth appearance, and over here is kind of a jagged appearance, right? So the presence of that on x-ray will be quickly diagnosed as hip arthritis, and the presumption will be that's causing your pain. Signs and symptoms would be limited flexibility, as if trying to tie your shoes and put your socks on. Pain in the front or along the front of the thigh. Could be pain in the back and the side of the thigh as well. So that's symptoms that could be related to a condition of arthritis in the hip. Labral tears. Labral tears are common. They're not commonly diagnosed in populations over age 45 and 50 for a number of reasons. But the labrum is a connective tissue that increases the depth of the capsule of where that joint goes into. So the labrum is the top portion of the cup, if you will, of this joint. It's a rough cartilage tissue, and damage to that can occur with just being on the planet, or athletic injury, or some sort of slip and fall. Signs and symptoms could be sharp pain in the front of the hip, could be clicking or locking sensation in your hip, reduced flexibility of your hip, and sharp pain perhaps causing your leg to give away. Some of these signs and symptoms for these different problems may sound familiar from one thing to another. And that's just part of the deal. Bursitis. Bursitis are fluid-filled spacers that act as cushioners. There's the bony bump of your leg bone, and there's tendons and muscles that pass along there. So there's small bursa that help to provide a reduction of friction. They serve as little space washers. Bursitis is another condition that can occur. It's inflammation of that bursa sac. Signs and symptoms can include typically pain on the outer hip, swelling and warmth of that area. Pain worsens with sustained activity. Lower back referred symptoms. Could be a disc irritation, disc herniation, or some sort of nerve impingement in the lower back. Again, the hip joint, as you saw, is fairly close to the lower back. The nerves that supply the lower leg come from the lower back, so if the back is, if you will, jacked up, they're out of balance, there can be irritation of that nerve and causing pain into that hip joint. Signs and symptoms of that might be radiating pain that includes lower back, continues with the back of the pelvis to the side, front of the hip, maybe even down the leg. Could be some numbness or tingling that extends down the leg. And again, it may be the same sort of pain and stiffness, feeling a heaviness through that leg. There's a specialty condition that you probably will never hear of anywhere else. It's called Main syndrome, also known as thoracic lumbar syndrome. And what happens here is, in the lower back, there's 5 lower back vertebrae. Those are not connected to ribs. And then there's the vertebrae that are connected to ribs called your thoracic spine. That area where the thoracic spine meets the lumbar spine is where there's a couple of nerves that come out from the spine. They're superficial, they're not deep in the spine, and they actually run down the back to the back of the lower back of the hip, and even to the front, even into the groin. So if there's tightness, if there's a joint issue there, that nerve can become irritated and cause pain that mimics lower back pain. It can mimic hip pain. It can also mimic pain actually in the pelvis and even the genitalia. That's called thoracolumbar syndrome or Main syndrome. This is a top view, if you will, of a vertebrae. Cut away, those are the ribs, and that nerve exits from the spine area and extends down the leg. Classic treatment for this would be an injection into that area. Medical treatment would be an injection into that area, and if that calms down that pain, then it's presumed that that is the diagnosis. We don't advocate injecting that area. Simply mobilizing, manipulating, stretching that area out with precise activities will help diminish symptoms and help guide our ability to identify that. Again, that's a very infrequently examined or looked after thing. It's not well known about, and unfortunately I didn't know about this until about 10 years ago myself as a clinician, and that's a mistake because there are a number of people who have this. This condition is called regional independence. One part's connected to the next. So what you can have is, if you will, inability of the ankle and foot, knee, or lower back to be well balanced in movement. You develop a hitch in your get along, right? We don't move as a hip. We don't move down the road like just a hip joint, right? We move as a knee, ankle, foot. So if there's something kittywampus, you can have abnormal forces through that hip, causing a hitch in your get along, basically, right? Altered movement patterns affects the biomechanics of the body, compensation patterns, and people get used to this all the time. Oftentimes, people walk and they got kind of a hitch, and they just got used to it over the course of years, right? Oftentimes they'll say, when you walk, you kind of do this side lurch, you got this going on. Do you know that? No, not really, because they get used to it, right? But it can get to the point where it does cause aggravation, because once the body starts moving out of ideal type of arrangements, you start to develop abnormal forces through the body, and that can cause pain as well. Hip flexor imbalance. Like, there's all kinds of gadgets sold on Facebook right now to manage hip flexor tightness and hip flexor problems. It can be a problem. So there's a particular muscle, and I'm not sure how well this illustration shows it. I'll probably have to blow that up for future presentations, but there's a hip muscle that's it starts at the spine, the front of the lower back vertebrae. It comes down and it passes through the back of the pelvis. It hooks up with another part of that muscle that's connected to the back of the pelvis, and it comes down to your hip bone here. That muscle, when it shortens, brings the foot up, and when it lengthens, it should allow the leg to come underneath it. So if that muscle is here and that muscle gets tight and spastic, it'll limit the flexibility, and then people will feel bent over and they won't have as much ability to move on that. If not addressed and treated, that'll stay with folks. That happens oftentimes if we start to, over time, decrease our stride length and stepping length. We start to take shorter steps. That can become short on its own. That's important because ultimately in the world, what do we need to do? We need to be able to stand upright against gravity. We need to be able to walk. That involves opening that up. If that hip flexor is tight, that'll limit correct alignment of that, and we'll end up being more comfortable in the forward lean position. There's specific tests and measures we can do in the clinic to see if that's going on, and specific procedures to help with that. So individuals might experience pain in the front of the hip. They could experience lower back pain. Again, difficulty standing from seated position, and oftentimes they will feel a hitch in their walk. But maybe they'll just adapt to a poor walk pattern over time and just think, well, that's just the way it is. I'm getting a little older. Ankle and foot imbalances can cause issues, as it's easy to imagine that if that ankle and foot doesn't control your weight properly, that nothing above it feels steady, and then that could develop an issue as well, right? So you kind of see here, this is kind of an illustration of things nicely stacked over each other with a nice arch in the foot. There's a collapsed arch. There'll be a tendency for if you will, malalignment from the foot up. And oftentimes we think, oh, well, can something be done for it? Sure. Do I have to have a rigid foot orthotic? No, you can certainly train muscles at the hip, train muscles at the foot, and train flexibility in the ankles to help compensate for that. And then we want to improve someone's walking pattern, of course, with that. So they don't have, how many steps a day do you think you guys take? Just a survey, how many steps do you think? Anybody track their steps? None of you track your steps?
A few thousands.
A few thousands? I'm sure most of you probably.
Walk 2 miles.
You walk 2 miles? Yeah, I'm sure you're doing 8,000, upwards of 8,000, 5,000 plus. Even individuals going about a relatively.
At one time you walk on one trip? Not some in the morning and some in the night?
I have a walking partner, and that's why I managed to get out there. It's very important. Go, think of excuses.
I love it, right? Whatever number of steps, whether it's 1,000, 2,000, or 8 or 10,000, right? Half of those are done with each hip, right? So you want to correct that imbalance so that you don't create those thousands of imprecise movements every day that will add to that hip irritation. Question for you, is it possible to have more than one issue at a time?
Yes.
Almost always, right? Here's the thing, it can be a common experience for people to experience pain in the front of the hip, side of the hip, back, front of the leg, down the leg, back, knees, right?
Mm-hmm.
Even if two people present with the same symptom areas, rarely do two people have the same profile. Usually there's a combination of those different things, right? Early on in my career and clinical training at that time was focused on you find the one thing that's going on with that person and we look to fix that one thing. Historically, that one thing has been surgery and injections or maybe some simple exercises. We've come a long way in 30 plus years that have been a profession, and when we look for a wide variety of things that could be influencing that, decide what's going on for that individual, and then work through those problems, then people get much better results. That's the spoiler alert. So, common signs across most of the issues that we talked about is going to be pain in the hip or groin, limited flexibility of your hip, oftentimes difficulty getting on your feet, and your walk has changed. Doesn't feel as smooth as you'd like, doesn't feel as fast as you'd like, doesn't feel as comfortable as you'd like. You may be using more energy to walk than you'd like to. Differentiating factors might be the location, the precise location of those. Might be looking at what's exactly is bringing them on and turning them off, night versus day, that sort of thing, and other associated symptoms. And then this is most important, expert physical examination, not just looking at x-rays. I remember I reviewed a study by a researcher called Hoeksema, Dr. Hoeksema and his team in 2014. And it was believed, and still believed now, that if you have arthritis, moderate to severe arthritis, that the only thing to manage it is hip replacement surgery. This research project took individuals who were headed into surgery, they were scheduled for surgery, and they devised a very specific treatment protocol. Aggressive exercise and aggressive mobilization to the hip joint. You might see maybe not the aggressiveness of that, you might be some indications of that, but essentially this hip joint is tight. Yes, there's some changes in the connective tissue there. You can see some changes in x-ray, because typically they show that, and the orthopedist proudly shows that, oh, that's where your arthritis, we're going to cut that out and replace it. That's a viable option. This treatment program involved exercise of those major muscle groups around the hip to strengthen that up, warm it up, and aggressive types of stretching in all directions, and then re-educate the walking. What they actually found that individuals who have even severe arthritis were able to get so much symptom relief that they decided not to pursue surgery. Not all of them, but a significant number of them. find that in the clinic as well, that for those individuals, even with profound arthritis in the hips, if they're willing to go through the treatment plan, they oftentimes realize they don't need to, or at least they can put off that decision down the road, even with bad arthritis. But it starts with an expert physical examination and not just concluded from the x-ray reports that, well, you got bad arthritis, that's your only option. When do you want to schedule, right? So for individuals who want to do that, that's fine, right? But there may be other options for individuals. Key to getting the root cause of that is a proper examination. You'll see a part of that today. Not just looking at the x-rays and not just looking to do things to mask the symptoms, but get to moving through the problem. So what we're going to do now, if that's okay, I'd like to do what we call a 5-minute miracle, and that's a chance for you to see what an assessment looks like of a hip problem from somebody in the audience, and what the type of intervention might look like for that individual, and you can gain a little bit more understanding of what that looks like. Before I do that, any burning questions about any of the material we presented so far?
What is the name of the one that's often missed when they diagnose the hip problem?
It's called Maine syndrome, M-A-I-G-N-E syndrome.
Thank you.
Welcome. Who feels like they have stiffness in their hips, like when they're tying their shoes?
Yeah.
You, Judy, you do?
At times.
At times?
I can still do it.
Oh, I still do it too, yeah. I'm sometimes stiff all the time.
Got it, okay. So, Judy, would you be willing to avail yourself to taking a look at this? You're a brave gal.
The worst part is the stiffness when you get up you sit for a long time and then you have to get up and start moving.
Mm-hmm.
But then when you're moving, I do better.
All right, Joe, come on. So. All right. So, Judy, what's going on? Tell us about what you're experiencing.
Well, so my hip hurts here at times, and then through here. Like, if I'm vacuuming after a while, my hip will hurt. I'm walking a ways, my hip will hurt. Sometimes I get up and my hip hurts.
Got it. Also, when you first get up in the morning.
I'm really stiff in the morning.
Yeah.
All over I'm stiff. So I have this little routine of exercises that I do. I flex my knees, you know, those heel slides that you do.
Mm-hmm.
I do ABCs with my feet. I do finger things in order for me to get moving in the morning.
Got it. Okay.
So, am I stiff? Yes.
Got it. And the
How about when
hip.
you sleep?
What?
Do you have pain when you sleep?
Sometimes, but I can almost sleep through anything, so I guess
And it's your right hip.
my right hip is the one, yeah, that seems to bother me the most.
Got it. Okay. And do you notice in your walking as well at times?
Yes.
Okay. So, great. So in an actual consultations, we might obviously we will go into a little more detail than this, but this gives you some really good information. I think the next thing, if you would please, I'm going to have you just walk back and forth in here. And we're just going to take a look at what walking looks like. So things don't have to be a trained clinician, just you continue to walk to keep, to identify where there might be some limitations. So does it look like her right leg moves as much through the walking cycle as her left leg? Or is it a little bit shorter there? What do you think?
She's moving a little bit this way, a little bit. She's kind
Not quite as much follow through over that leg. Do people see that? It's a little different right to left. So just take notice of that. So
Okay, I never paid attention.
Right? Right. It's something that she's adapted to over a long period of time. It's not as if I would see her walking down the street and try to rush to her aid. Like, oh my goodness, ma'am, are you okay? Right? But it's easy to see that she doesn't put weight over that leg as well. So we'll see how that changes, with this session if it changes. So the next thing I'd like you to do, if you don't mind, is do you know about squats? I'd like you to just kind of put your feet apart a little bit and go into slowly, comfortably, the squat to the depth that you can. So that's going to also assess some hip movement. So slow it down a little bit and think more about bringing your bum to the floor than your feet to than your hands to the floor. Okay. Any bother with that?
No,
Okay.
that actually feels good.
Feels good. Okay. We're going to investigate this a little bit further. Would you stand on your left leg, please?
My balance is not very good.
Okay, thank you. And now stand on your right leg. Okay. So if we take a look at standing on your left leg once more, go ahead and stand on your left leg. Notice your hips stay fairly level. Leave that go. Stand on your right leg. And her hip tends to drop a little bit. Do you see that? Okay, so the muscle control around that. You may not see it, but your shoulders drop a little bit. So she's not accustomed to staying stable on that side. So
I have seen that.
every step that she takes is a little bit off. She's adapted to that. She's accustomed to that. I'm not picking on her.
I understand.
All
I
right.
guess that's why I'm here.
So if you would, I'm going to have you, I'm going to get the table out. If you wouldn't mind, have a seat on your chair there. I'm going to move the table a little bit. So the first thing I'm going to do is assess movement here. So I want to see how much your hip moves up here. And so this is at about 90 degrees or a right angle. We want to see how much movement she has beyond that. So there could be a little bit more movement there, but that's not horrible. In movement, that's about what we'd expect. This out movement, not too bad either. I'm going to do a couple of other things. Going to apply a little pressure through here. Now allow me to move you. I'm just going to challenge that hip joint here. Is that bothersome at all?
No.
Ideally, that hip joint would be able to tolerate that movement, and that's a natural thing for it to be able to do. You're going to place your foot on your other thigh. Let this knee come to the side. This knee should come down a fair degree towards the table and take end range pressure. So that's a pretty healthy mobile knee. Excuse me, hip.
It has been replaced, just a minute.
Okay. This one. Is that as flexible as the other one? No. This movement, not too bad. Not a lot doing here. And just let your leg relax as best you can. Apply a little pressure here. What does that seem like?
It hurts.
She doesn't like that. Right? Big difference right to left. That joint is not happy. Place this here, and how about here?
It's okay. Now it does.
Yeah.
I can do that.
So she's got, we call it capsular pattern of tightness in that hip joint. So your left hip is replaced? What
No,
hip?
neither hip is replaced.
Oh, neither hip is replaced.
Both knees are.
Oh, both knees are. Okay, got it. How long ago has this been replaced?
That was done in 2000 and December of 2019.
So what I'm going to do is we're going to do a little bit of stretching out of that hip joint. There's a number of different ways to do that. We're going to choose a really simple way. I'm just going to do a little bit of traction to her hip here. I just use the belt to help make it easy for myself and comfortable for her. So what we're doing here is stretching that hip joint out a little bit in the hip joint capsule in order to get at some of those tissues that you can't get at after with self-stretching. And just doing a little bit of stretch here. How is that for you, Ginny?
Okay.
Comfortable? Now she's got a knee replacement, so I'm not going to be being overly aggressive with this. So this is going to be gentle. It doesn't have to be aggressive, but it has to be targeted and specific to that hip joint capsule. Do you feel like there's a little bit of stretch deep into that hip joint?
I can feel it, yes.
Good. So we have the internal sense of the hip joint and any joint in our body. And this is isolated mobilization there. And again, I'm not applying a lot of pressure. I'm just leaning back just a little bit of pressure. Comfortable for the ankle and foot as well?
Yes.
Comfortable for your knee?
Yes.
Great. This can also provide a little bit of traction through the lower back as well, which can relieve back-related hip pain as well. From a spectator's view, this can maybe look a little bit like watching grass grow, paint dry. Not a lot of action there, but you can feel movement in that joint.
Yes.
Okay. So now we're going to reassess this. Bend this knee up, please. And they're going to reassess movement here. What do you see? What do you feel about the movement? What do you see about the movement now?
It
What do you notice?
doesn't hurt as much.
And apply pressure in there. That's still a little saucy.
Yeah, but it's not bad. It's
Not as
not like
much.
before.
And let this come out to the side. A little bit more movement there. Terrific. 5-minute miracle. So I'm doing the happy dance. Why am I doing the happy dance? Because we can get a change with one simple procedure that's targeted, which means that if we do that in combination with some other things enough, that hip will regain likely all of its mobility, and then we can train the muscle function to get stronger in that and work to improve her walking.
I like that.
Very simply, right? Have a seat, please. Sit for a moment.
So do you ever feel that like the same motion should be done on the other hip too? Or not necessarily? It doesn't have to be equal. We just work on the hip that's causing the problem at the time. I don't know.
So we're going to start with the area that is most restricted and
Okay.
most going to impact her change.
Okay, that's what I thought.
There are times when people have significant tightness in both hips,
Mm-hmm.
and both need to be addressed, even though one is barking a little bit louder.
Okay.
At the end of the day, and that's a great question, right? At the end of the day, we need to move in the world.
Mm-hmm.
I want ability for individuals to be able to easily not only get up and down from a chair or a low toilet or a low car, but also easily up and down from the floor if they choose. To be able to have the strength to go down into a deep squat to pick something up off the floor. To be able to go into a lunge to pick something up like a pot or something off the floor, some groceries. And in order to do that, all those parts have to move well, right?
Right.
So, great question.
Okay.
Come on up, and what we'd like to do now is just kind of take a walk and just notice for yourself the feeling state of that. We'll just watch her move. And sometimes it becomes pretty apparent that it's changed. Other times, maybe not so much.
I don't
I don't
know.
know what anybody recognizes. She still has some issues with the walk. I don't know if it's substantially changed, but I think it's a little bit, right? I don't have as many objective measures for that right now, but that might be a little bit changed. One thing that'll be interesting, go ahead and stand on your right leg once more. So she's still got a balance issue, but
Right.
that's stacking a lot better. Did you notice that? Her shoulder and other hip doesn't drop as much, right? So even with that, the body loves this. The body wants to get to a state, like we're biological beings, right? And we provide some sort of change. Thank you so much. That's awesome. I appreciate that. The body wants to move better, and once we give it the opportunity, get a little bit more flexibility, and then we ask it to do things, it's going to take that information and use it. Now, she needs to do more stuff than that, right? Because there's still some stiffness in there. Early on in the plan of care, we're doing a lot to relieve that stiffness and pain. As the plan of care continues, we're going to train the muscle strength so that you can balance better. Because that's not just all balance in the brain control centers, but some of that is the muscle control of the hips. We haven't looked at her back really. There might be some issues going on in her back, although I don't have anything that jumps out at me, but we're going to look at her back and how it functions. I'm just trying to grab the easy fruit, right? Like what's the thing that we need right
What's
away?
the shoulder has to do with the head? Did you see the shoulder is down a little bit?
Yeah,
See, I have
Well,
the
it's-
same thing, my shoulder is
yeah.
dropping, not even.
Well, there's two
Because
things.
that's
So
hip.
so when Judy was trying to stand on one leg, she wasn't able to control it from the hip, so she's trying to make up for it with this stuff,
Even when I
right?
walk, that one down,
Yeah, there could be
Right.
other things that cause shoulder unevenness, right? So it could be some stiffness
Yes,
in
yes,
the
same
torso.
thing. I do.
It could be, yeah, could be, right?
Hmm.
So we move individuals and we talk about, like, is that all we're gonna do in treatment sessions is pull on her leg, right? Probably not, right? Like, not at all. So what we're gonna do is we're gonna move through a plan of care in which we address that main problem to help alleviate that pain and symptom, and then build increased flexibility and strength for that muscle, and then help her through a plan of care where she gets more confident in walking, moving, bending, twisting, develop an exercise prescription that's individualized to her, progressed over time, so that at the end, relative to what she wants to do, get a nice tight bit of exercise prescription that might include some flexibility exercise that she adds to what she's already doing, maybe one or two strengthening things that she's not including in her program, so that she can sustain that improvement over time. So we're not about necessarily, like, we want people to come back to us on a regular basis if they need to, but we want to kind of wrap that up, fix it, solve it, help them self-management to the extent that they can. Then come back and see us for something else.
Which is doing.
And that's okay too, right? But that's if you will, the plan of care that we follow, right? It's individualized to her, it's adapted. No two treatments are exactly the same, no two plan of care are exactly the same. She's obviously gonna need more sessions. So, we talked about, what does a plan of care look like? Individualized treatment plans. And we need personalized intervention based on the assessment, right? Hands-on work, manual therapy, that's key here. Physical therapy should not and was never designed to be a list of exercises, right? You can get that online, you can get that from Pinterest, you can get that from the trainer at the YMCA or the senior center. That's not what we do. We use an exercise prescription to help get to the next level of recovery. We want to help develop strength in whatever areas we need to, in the hips, lower back, ankle, foot, whatever you need. If someone's having trouble with single leg balance, maybe they need some work on their ankle and foot to get increased flexibility and strength. Maybe they do need some balance training. Whatever it takes to get that person to the next level, we'll help them with. We use joint mobilization techniques to literally direct forces to increase flexibility of that joint. We can do muscle massage work. If there's some muscle irritation around that area, which we didn't really do a big assessment today, we can do deep tissue muscle massage work, some of which with tools, including myofascial release. And then we want to target strengthening exercises, particularly around the hip and lower back, and progressively strengthen tissues. I'm a big fan of strength training. We should do more of that. At the end of a plan of care, everybody should have the strength to be able to do a deep squat and to be able to do a lunge movement to pick something up off the floor or easily get up and down from the floor. Which some people look at it like, oh, I don't think I can do that. I'm like, we're not forcing people to do that, but your body's a lot better when we train and can get closer and closer to that. Because when you get up and down from a chair, you're squatting. And the better you can squat, the better you get up and down from chairs. Dry needling is simply use of acupuncture needles that can help address pain and issues that might be coming from nerve irritation. And that people don't necessarily have to have that treatment, but for those that want to avail themselves to it and under recommendations, it can be a really nice additional treatment effect.
Do the results from that last a long time, or do you have to have that done every time you come in?
The needling?
Yeah.
So it kind of depends on the condition, but typically we use it for a period of time, 4, 8 sessions, and then
Oh,
we
I
don't
see.
necessarily,
Okay.
you know.
It's wonderful.
Really?
Yes.
My friend did it and she was very happy with it.
Yeah, there's some individuals that hate needles. Like, I'm not having any needle near me, even though you can barely see them, right? Like, I'm not a big fan of needles, but when I need it, I'll avail
You
myself
have
to it.
pain the first couple of days, right? Everybody have a pain the first couple of days from
No,
it? No
Yeah.
pain?
I've had a couple of patients who just 1 or 2 needles and they jumped off the table. Like in 10 years, I can think of 3 or 4, maybe 5 people. I'm never having that done again. Those are rare. On the other end of the spectrum, they don't feel anything when they go in. Most people feel like, oh yeah, it feels like something going in, or maybe like a mosquito bite, but that's about it. But when the nerves are irritated and jacked up from some pain conditions, it can be a
Second
little
day
bit.
you feel it.
It can be a little bit jacked up. Sure, sure. Everybody's a little bit different. We're a big proponent of anti-inflammatory supplementation as an alternative to over-the-counter or prescriptive medications for anti-inflammatories. Curcumin is one of them. Collagen for joint support. Collagen is one of those supplementations that has shown to decrease not only the inflammation but also help build cartilage tissue in human trials. No other supplement I've seen does that. And then fish oil for those that take that. So, when's a good time to consult a doctor or physical therapy? When pain keeps you from standing or walking for more than 30 minutes. Keeping up with
Standing
friends.
and walking.
Yes. Keeping up with friends and family. Keeping up with your yard and home. And keeping you from joining your exercise and gym buddies, right? That's a good time to get some help, right? Particularly if you're fearful of losing your independence or don't want to look at people worrying about you and for those that continue to slather on things, put on braces, repeatedly applying ice packs while not getting better. If it's for a short period of time, a couple days, perhaps, but if you find yourself doing that, there's an underlying condition that needs some help. And particularly if you're interested in minimizing drugs, surgery, or injections, and do not want to be reliant on others for muscle, bone, and joint relief. So, a modern-based doctor of physical therapy provides a plan of care that includes joint mobilization and manipulation. You saw that there. Can provide deep massage work for muscles that are irritated and tight. Develop an individualized exercise prescription that's individualized to that person and progressed over time. And develop a strengthening program to keep someone strong for their active life. And potentially provide pain relief for those that are open to it and when clinically necessary. That's not a necessary consideration. As always, there's not too many hips we haven't been able to help. And if yours is one of those we're like, not sure if we can help you, we'd let you know. Right? So I'm excited to come to work every day because I believe modern doctor physical therapy is the best plan of care for people that want to look at non-drug, non-prescriptive care to get back to active life. There's a ton of ways to get pain relief. You can have a drink, get a massage, you can take some medications, you can slather on some CBD with or without the happy stuff. A lot of different ways to get to pain relief. We help with pain relief, but what we're interested in is helping not only with pain relief, but getting people back to their active life. So this is just an illustration of our progression through a plan of care in which early on we want to relieve pain and inflammation. Then we want to correct the root cause. So you see someone kind of bent up, oh, I can't quite move well, start to get a little taller and stronger. We want to strengthen within that newfound range, and then we want to preserve that ability with that prescriptive care. Brian, if you wouldn't mind, we'll gather up the crew. So, Brian, you want to take a crack at next step?
Yeah, definitely.
Okay, so that's the dog and pony show, if you will. So again, Brent will help guide what the next best step is for individuals who want to get individualized look at their session. And thank you so much for your attention.